Hello friends, today we are going to discuss about an important condition. We'll start with the case. A young patient with palpitation comes to ER. He is vitally stable and there are no comorbidities and he is not on any medication. So when ECG was taken for this patient and showed, so whenever there is ECG you have to calculate rhythm first. See, the distance between two R waves, it is regular here. Almost 10 small boxes or 2 large boxes. See here, there are 2 large boxes between 2 R waves. So rhythm is regular and rate is there are 2 boxes. 300 over 2 is 150. So rate is around 150 beats per minute, which shows tachycardia. And axis you have to see. For axis determination, you have to see lead 1 and lead AVF. In lead 1, QRS is predominantly downward and lead AVF QRS is predominantly upward. So both are reaching each other. Reaching each other means R for R, right axis deviation. And you see the QRS morphology. They are narrow. That is normal in duration. That is less than 120 milliseconds. They are narrow in appearance. They are less than 120 milliseconds normal. So it is narrow complex tachycardia. So narrow complex tachycardia, but there are no P waves and regular rhythm. Regular rhythm, narrow complex tachycardia with no P waves means it is AVNRT or simply called as PSVT. So once you made the diagnosis of PSVT, so this ECG is showing PSVT. Narrow complex tachycardia with a regular rhythm with no P waves, PSVT. So once you make the diagnosis of PSVT, you have to manage this case. For that, you should know whether the patient is stable or not. So since the question mentions patient is vitally stable, we have to manage like this. What if the patient is unstable? If the patient is unstable, you have to go directly to synchronized DC cardioversion. So in our patient, the patient is stable, so we are going to try for vagal maneuvers. So what are these vagal maneuvers? We can do carotid sinus pressure, pharyngeal stimulation, or Valsalva maneuver, and diving reflex, and forceful coughing and ocular pressure. So most commonly done is carotid sinus pressure. So how it is done? Carotid sinus pressure is done when the patient is in supine position and neck should be hyperextended, and you have to palpate the carotid artery and go distally as possible near the angle of the mandible. So there you have to feel for the carotid artery and press it for 5 seconds, not more than 5 seconds. You press it for 5 seconds initially, and while doing this carotid sinus pressure, you have to monitor the patient. Continuous cardiac monitoring has to be there. So if the patient rhythm doesn't come back to normal sinus rhythm, you can try for other carotid artery. So simultaneously you should not put pressure on both the arteries at the same time. Simultaneously you should not do carotid sinus pressure, and carotid sinus pressure has to be done only when after ruling out any audible bruise over the carotid. So there should not be any audible bruise, and you should not do it on simultaneously both the carotids, and there should be continuous cardiac monitoring. So it's most commonly done maneuver for PSVT. So once it fails, you have to manage the patient with drugs. So what drug you want to give is adenosine. So before giving adenosine, you should rule out the possible contraindications for adenosine. One thing is of course allergy to adenosine, and another thing is bronchospastic diseases. Patient like asthma comes with PSVT, you should not give adenosine. Or patients with CCF, better not to give adenosine because it causes hypotension. So, and you should also ask the patient for the history of drugs. Is he on any anti-epileptic drugs? Okay. If the patient is on any anti-epileptic drugs like carbamazepine, or if the patient is on carbamazepine for trigeminal neuralgia. So if the patient is on carbamazepine and dipyridamole, these two drugs potentiate or increases the actions or effects of adenosine. So this patient who are on carbamazepine, they need a reduction of adenosine dose. So In other scenario, if the patient is on theophylline, or if the patient is excessive coffee and tea drinker, you have to use more, increase the dose of adenosine, because these two drugs, theophylline and excessive coffee and tea drinkers, they have antagonist effects against adenosine. So in that case, you have to increase the dose of adenosine. So how do you see? One extra point here you have to remember is, one average cup of tea has 1 mg of theophylline. This is just an extra information. Next, how much dose of adenosine has to be given? So first you start with 6 mg IV bolus as rapidly as possible, followed by 10 to 20 ml of saline flush. See, adenosine has to be given as proximal as possible, so it has to reach the heart very rapidly and very quickly. So what happens when you give the adenosine distally, before it reaches the heart, adenosine will be metabolized in RBCs. So it has to be given as proximally as possible, and if you give it in distal vein, you have to raise the limb after giving adenosine. Next, after 1 minute of giving 6 mg of IV bolus, you check for rhythm. If it doesn't come back to normal rhythm and patient is not hypertensive, you can give 12 mg of adenosine again. Again after 1 minute you reassess. If the patient doesn't come back to normal, you can give one more 12 mg of adenosine. So total adenosine dose is 30 mg. So what happens? 60% of the patients they respond to first dose of adenosine only, and another around 90% of the patient respond to first 12 mg of adenosine. So in 10% of the patients, all these medications doesn't work. So next, that time you have to give, or if the patient is contraindicated to adenosine, you have to use other drugs, other pharmacological methods. So those usage of those other drugs depends upon LV ejection fraction or LV function. LV, left ventricular, has two functions: ejection and diastolic function, systolic function. Systolic function is measured by ejection fraction. Diastolic function clinically measured by bilateral crepitations, signs of heart failure like pildor edema, ascites, JVP, PND, orthopnea, like that. So you have to check for LV function to start other drugs. If the LV function, that is left ventricular function, is preserved, what do I mean by preserved? LV ejection fraction more than 40% and there are no signs of cardiac failure. So that is preserved LV function. And if the patient is having dearranged or impaired LV function, like LV ejection fraction less than 40% and there is signs of cardiac failure, that time you have to give digoxin. Here you have to use digoxin. So what if the patient's LV function is preserved? If the LV function is preserved, you can use calcium channel blocker like verapamil. So verapamil 5 mg over 2 minutes, you have to give IV. So you assess for the rhythm after 15 minutes. If the rhythm doesn't come back to normal, you can give 5 mg over 2 more minutes again. Like this you can repeat up to 20 mg of verapamil is given. And verapamil is negative inotropic and hypotensive drug. So we can give diltiazem also, which is again a calcium channel blocker, but it is shorter acting and less hypotensive than verapamil. So 0.25 mg per kg over 2 minutes you have to give. After 15 minutes you can give 0.35 mg per kg. So it followed by maintenance dose of 5 to 15 mg per hour. See here, one important thing is 5% of 10 ml of calcium gluconate or calcium chloride has to be ready. When the patient develops hypertension due to verapamil or diltiazem use, you can inject calcium chloride or calcium gluconate 5% in 10 ml syringe to reverse the hypertension. Next, beta blockers. Beta blockers are used when the patient is not responding to above pharmacotherapy. So what here we can do is, you can use beta blockers, or if there is contraindication to beta blockers like congestive heart failure, hypertension or asthma patients, so you better avoid these beta blockers. So what are these beta blockers? You can remember them by EMAP. E is for esmolol, M for metoprolol, A for atenolol, and P for propranolol. So metoprolol can be given as 5 mg slowly for 5 minutes, and after 5 minutes you can repeat the dose, like you can give up to 15 milligram over 15 minutes. And atenolol is given 5 mg over 5 minutes. After 10 minutes you can repeat it. So these are the usages of calcium channel blocker and beta blockers in management of PSVT. They are used only when there is LV function is preserved and there is narrow complex tachycardia. And what if there is a left ventricular dysfunction is present, like in the form of LV ejection fraction less than 40% and there are signs of heart failure? You have to use digoxin. Digoxin is slow acting, less potent antiarrhythmic drug. So it is slow acting. Here you can use it by 0.5 milligram slowly IV for 5 minutes. After 4 hours, see after 4 hours it is slow, very slow acting. After 4 hours you have to see whether rhythm came back to normal or not. If it doesn't come, you can escalate the dose to, you can repeat the dose like 0.25 mg IV slowly you can give. After that you can repeat up to 1.5 mg over 24 hours. So this is about management of PSVT. Hope you understood it well, and this video may be helpful for you. If it is helpful, please give a thumbs up and comment below. Thank you.